Let me describe a situation that plays out in medical offices every single day. A person walks in for their annual physical. They feel well. Their energy is reasonable. They are sleeping, functioning, doing the things that matter to them. Their doctor glances at the chart and says something that sounds perfectly responsible. Let us just run a few tests to make sure everything is fine. 6 weeks later, that same person is sitting in a specialist's office. Not because something was wrong with them when they walked in, but because those tests found something. And that something set off a chain of events that a body in its late 60s or 70s is not always equipped to navigate without consequence. The life they were quietly living looks very different now, and not because of the condition that was found, because of what the medical system did in response to finding it. I am Dr. Richard Hale, and after years in clinical practice, this is the pattern that concerns me most. Not the obvious emergencies, not the patients who came in clearly unwell and needed intervention. The patients who came in feeling fine, underwent routine screening, and left on a trajectory they never expected and never fully understood. What I want to give you today is not a reason to avoid your doctor. It is a framework for having a fundamentally different kind of conversation with your doctor, one where you understand not just what a test is looking for, but what happens if it finds something, what the treatment options look like at your specific age and health status, and whether the math of benefit versus risk is actually in your favor before you proceed. There is a concept I want you to carry through everything that follows. The risk-benefit equation in medicine is not fixed. It changes with age. At 50, screening medicine works beautifully. You find a problem early, you treat it, and you potentially gain decades of healthy life. The investment is clearly worth it. But after 65, and particularly after 70, three things change simultaneously. First, many conditions detected by routine screening in older adults grow so slowly that they would never cause harm within a person's remaining lifetime. They are there, but they are clinically irrelevant. Second, the body's capacity to tolerate medical intervention declines with age. A procedure that a 55-year-old recovers from in 2 weeks can mean months of complications, loss of independence, or worse, in a 75-year-old. Third, there is what researchers call the cascade effect. One test finds a small abnormality. That triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And a person who walked in feeling perfectly healthy is now navigating a medical crisis that originated not from illness, but from a test result. Understanding this framework changes everything about how you evaluate the 5 tests I am about to walk you through. Stay with me, because some of what follows will genuinely surprise you. Before I continue, if you are finding this useful, if you feel like you are getting the kind of clear, honest health information that most 15-minute appointments never have time for, please consider subscribing to this channel. My goal is to bring you evidence-informed content that helps you understand what is actually happening in your body and in your care. Hit the subscribe button. It takes 2 seconds, and it helps this information reach the people who need it most. Now, let us get into the 5 tests. Test number 1 is routine colonoscopy after the age of 75, and this is the one where the guideline bodies have actually reached a clear consensus that most patients never hear about. The United States Preventative Services Task Force, the organization that sets evidence-based screening guidelines in this country, officially recommends against routine colonoscopy screening for average-risk adults over the age of 75. Not as a suggestion, as a formal recommendation based on a careful analysis of the evidence. The reasoning is straightforward and worth understanding in detail. A colonoscopy is not a risk-free procedure. Bowel perforation, a literal tear in the colon wall, occurs in approximately 1 in every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 75-year-old, it can mean emergency surgery, extended hospitalization, and a recovery that fundamentally alters quality of life. The colonoscopy preparation itself, the large volume of liquid required to clear the bowel the night before the procedure, places significant stress on the kidneys and the cardiovascular system. Research has documented cases where older adults experienced severe electrolyte disturbances from the preparation that required hospitalization before the procedure was ever performed. And here is the critical piece of context. The colon cancers most likely to be detected by routine colonoscopy in asymptomatic older adults tend to grow slowly. Research has consistently shown that many of these cancers, if left undetected and unintervened upon, would never cause symptoms or death within the patient's natural remaining lifespan. The detection and treatment of a clinically insignificant cancer carries real procedural risk, with no genuine benefit to the patient's longevity or quality of life. What changes this equation entirely is the presence of symptoms. Blood in the stool, unexplained and persistent changes in bowel habits, significant abdominal pain, unexplained weight loss, a family history of colon cancer or polyps, these are reasons to discuss colonoscopy with your doctor regardless of age. Symptoms change the clinical picture completely. What the evidence does not support is routine screening in asymptomatic older adults with clean prior scopes and no risk factors. A reasonable alternative for monitoring purposes is a non-invasive stool-based test. Options including the FIT test and the multi-target stool DNA test can detect warning signs of colorectal disease without the procedural risks associated with colonoscopy. The question to ask your doctor is straightforward. Given my prior screening history, my current symptoms or lack of symptoms, and my age, is the benefit of a colonoscopy genuinely greater than the risk at this point in my life? Test number 2 is aggressive cancer screening in older adults without symptoms, specifically routine PSA testing and annual mammography, and this is an area where the concept of overdiagnosis is essential to understand. I want to be absolutely clear about what I am and am not saying here. Cancer screening has saved millions of lives and continues to do so. For individuals with symptoms, family history, genetic risk factors, or known prior findings, screening is entirely appropriate and should be discussed with a physician. What the research literature increasingly documents is a specific and serious problem with routine, aggressive cancer screening in asymptomatic older adults, which is that modern imaging and laboratory technology is now sensitive enough to detect biological abnormalities that would never, in the patient's remaining lifetime, cause harm. These are cancers that are biologically present but clinically irrelevant. They grow extremely slowly, they produce no symptoms, the patient would not die from them and would likely never know they existed. But the moment a radiologist writes a finding on a report, the clinical system responds to that finding. Biopsies are arranged, specialist referrals are made, treatment decisions are initiated, and all of that activity carries real risk, real side effects, real impact on quality of life for a condition that was never going to harm the patient. Research published in the New England Journal of Medicine has found that a substantial proportion of cancers detected through mammography in older women were clinically insignificant, meaning that treatment provided no survival benefit while still carrying the risks and side effects associated with cancer therapy. Similar evidence exists in the prostate cancer literature, where research has documented meaningful numbers of men who underwent radiation or surgical treatment for low-grade, slow-moving prostate cancer that would not have affected their lifespan, who then experienced significant decline in urinary function and quality of life as a direct result of the treatment. The question that most older patients are never asked is this: if we find something, what are the realistic treatment options for someone your age and health status? And would the treatment for what we are likely to find actually improve or extend your life, or would it primarily expose you to treatment side effects without meaningful benefit? That conversation, had before a screening test rather than after an unexpected finding, changes everything about how both patient and physician approach the decision. Test number 3 is routine cardiac stress testing without symptoms, and this one surprises people most because the reasoning behind it sounds so sensible at the outset. Your doctor recommends a cardiac stress test. You are in your early 70s. Your doctor wants to make sure your heart is functioning properly. You exercise on a treadmill or receive a medication that temporarily increases cardiac demand while your heart is monitored. This sounds responsible and thorough. The problem lies in what the test actually produces in older asymptomatic adults. Research has documented that cardiac stress tests in people without symptoms of cardiac disease have false positive rates that can reach 40% or higher in certain older populations. That means that nearly half of the abnormal results in this group do not reflect actual cardiac disease. They are false alarms. But medicine cannot simply note a false alarm and move on. An abnormal stress test result requires clinical response. That response typically involves cardiac catheterization, a procedure in which a thin tube is threaded through the blood vessels, usually through the wrist or the groin, and guided directly into the heart. Catheterization carries its own procedural risks, including bleeding, vessel damage, arrhythmia, and in a small number of cases, it can trigger the very cardiac event the test was trying to prevent. If the catheterization finds a partial blockage, which is extremely common in adults over 70, even in those who are asymptomatic and functionally healthy, treatment often follows. Research from multiple large clinical trials, including the extensively analyzed ischemia trial, has found that stenting in patients with stable coronary artery disease and no acute symptoms does not reduce the rate of heart attacks or extend life compared to medication and lifestyle management alone. This is one of the most significant and underappreciated findings in cardiovascular medicine of the past decade. The stent carries procedural risk and commits the patient to long-term blood thinning medication with its own bleeding complications, and the outcome data shows it offers no mortality benefit over optimal medical therapy in stable patients. The practical implication is this. If you have no chest pain, no unexplained shortness of breath during activity, no episodes of dizziness or near fainting, routine cardiac stress testing is looking for problems in a population where problems are common, where intervention does not necessarily help, and where the cascade from a false positive result can cause meaningful harm. The better investment, supported by far more robust evidence, is in optimizing the modifiable factors that actually drive cardiovascular risk: blood pressure, blood sugar, physical activity, sleep quality, and inflammatory burden. These are where the genuine gains lie. Test number 4 is routine bone density scanning, followed by automatic long-term medication, and I want to address this one carefully because osteoporosis is real, and fractures in older adults carry serious consequences. Bone density declines with age. Falls represent one of the most significant health risks for adults over 65. Fractures of the hip, spine, and wrist can dramatically alter independence and quality of life. All of that is genuine and important. What I want to draw your attention to is a specific pattern that the research literature has identified, which is the automatic pipeline that often follows a DEXA scan result in asymptomatic older adults. A DEXA scan detects reduced bone density. A medication is prescribed, typically a biphosphonate such as alendronate or risedronate. The patient takes it for years under the assumption that their fracture risk is being meaningfully managed. What is frequently not discussed is that long-term bisphosphonate use has been associated with a condition called atypical femoral fractures, stress fractures in the thigh bone that occur spontaneously without trauma. The bisphosphonate medication, taken to reduce fracture risk, has been associated in the research literature with a specific type of fracture in long-term users. Additionally, these medications have been linked to osteonecrosis of the jaw, a deterioration of jawbone tissue that is painful and difficult to manage. Meanwhile, the intervention with the most consistently documented effect on fracture prevention in older adults is not pharmaceutical, it is fall prevention. Research has found that structured balance and strength training programs reduce fall risk significantly in older adults. Specific research into Tai Chi has documented fall risk reductions of approximately 50% in older populations who practiced it regularly. Environmental modifications, removing trip hazards, installing grab bars, checking for medication side effects that cause dizziness, ensuring adequate vitamin D and protein intake, optimizing vision, these interventions work. They carry no medication side effects, and they address the actual mechanism through which most fractures occur. There absolutely are patients for whom bisphosphonate therapy is clearly indicated and beneficial, those who have already sustained low trauma fractures, those with very low bone density scores, those with specific risk factors that make intervention clearly appropriate. The question worth asking before automatically starting long-term medication following a routine scan is this: what is my actual fracture risk based on my complete clinical picture, and what evidence-based non-pharmacological interventions should we be putting in place alongside or instead of medication? Test number 5 is routine carotid artery ultrasound screening in asymptomatic patients, and this is the one that most people have genuinely never heard about until they are already in the middle of the clinical process it can trigger. A carotid artery ultrasound examines the large blood vessels in the neck that carry blood to the brain. The premise sounds entirely logical. If we can find a significant narrowing in these vessels, we can address it surgically and reduce the risk of stroke. The United States Preventive Services Task Force, however, explicitly recommends against routine carotid artery screening in adults who have no symptoms of cerebrovascular disease. Their recommendation is based on a careful analysis of the evidence showing that in asymptomatic individuals, the harms of screening outweigh the benefits. Here is why. The surgical procedure used to treat a carotid artery blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately following the procedure. In older adults with additional health conditions, that risk is higher. Many adults over 70 have some degree of narrowing in their carotid arteries. That narrowing is often stable, has been present for years, causes no symptoms, and poses no imminent threat. When routine screening identifies it, the clinical system responds to the finding. A surgeon may recommend treating a blockage that was never going to cause harm, and the treatment itself can dislodge a piece of plaque that travels directly to the brain. The symptoms that do warrant urgent evaluation are clearly defined and should never be ignored. Sudden weakness or numbness on one side of the body, sudden difficulty speaking or understanding speech, sudden vision changes in one eye, sudden severe headache without a clear cause. These are symptoms of transient ischemic attack or stroke and require immediate medical attention regardless of any prior screening history. What the evidence does not support is routine ultrasound screening in individuals with none of these symptoms, where the risk of triggering a harmful cascade through the discovery of an asymptomatic finding is greater than the benefit of finding and treating it. Let me bring this together with something practical, because the goal of everything I have shared today is not to make you skeptical of medicine, but to make you a more informed participant in your own care. Every time your doctor recommends a screening test, particularly if you are over 65 and currently feeling well, there are 5 questions worth asking before you proceed. First, what is the false positive rate of this test in people my age? And what happens clinically if the test produces an abnormal result that turns out to be benign? Second, if this test finds something, what are the realistic treatment options for someone my age and health status, and would that treatment genuinely improve or extend my life? Third, what are the procedural risks of any treatment we would likely pursue if the test is abnormal? Fourth, what happens if we choose to monitor this rather than treat it immediately, and is watchful waiting a legitimate option for what this test is likely to find? Fifth, what is the most effective non-invasive intervention for this condition, and should we be doing that regardless of what the test shows? These are not confrontational questions. They are the questions that any thoughtful physician should welcome, because they shift the conversation from what the test found to what we should actually do about your health. A good physician will engage with these questions seriously. They reflect exactly the kind of shared decision-making that modern evidence-based medicine calls for. I want to close with this. The goal of healthcare after 65 should not be to generate findings. It should be to protect and extend the quality of your life, your independence, your energy, your ability to do what matters most to you. Sometimes that goal is served by aggressive testing and intervention. And sometimes it is served by doing less, monitoring more, and focusing energy on the modifiable factors that the evidence most consistently shows make a difference. You have the right to understand which situation you are in, and you are now better equipped to ask the questions that will help you find out. Everything I have discussed today is for educational and informational purposes only and is not a substitute for professional medical advice. These are considerations worth raising with your own physician in the context of your specific health history, your individual risk factors, and your personal values and goals. Your doctor knows your situation in a way that any educational video cannot. What I am giving you here is the framework to have a more informed and more complete conversation when you get there. If this video gave you something useful, please subscribe to this channel and share it with someone in your life who is navigating health decisions after 65. Leave a comment below and tell me which of these 5 tests surprised you most. I read every comment, and your questions shape what I cover next. I will see you in the next one.